Okay, so Epidural Analgesia, it is the next station in critical care. So, second post of the patient following lobectomy using thoracic epidural. Now, patient has developed hypotension, bradycardia, desuturation, upper limb paresthesia, and oliguria. Mr. Alex is a 72-year-old gentleman who has undergone a left lower lobectomy and is on HDO. He is currently comfortable with thoracic epidural in place at the level of T3 to 4 with fentanyl and bupivacaine as a continuous infusion. His current observation is BP 80-50, heart rate is 70, spirit rate is 28, urine output is 15 ml per hour. His chest drain is functioning normally with slight air leak and fluid loss of 100 ml. So patient is unstable, and what are your differential? So based on this situation and condition, my first differential will be high epidural block. High epidural block and distributive shock, because patient is in a state of shock. He is low HP and okay. So here is a point. Patient has low BP. BP is low, but heart rate is normal. So how is this possible? Yes, this is possible. This is in neurogenic shock. This is a neurogenic shock. So high epidural block leading to neurogenic shock or distributive shock secondary to epidural, and paralysis of intercostal muscles, paralysis of diaphragm, because he is desaturating. So why patient having bradycardia? High epidural blocking of the cardio accelerator fibers, sympathetic fibers. For example, the sympathetic fibers are thoracolumbar from T1 to L2. So T1 to T5 unopposed parasympathetic action of the vagus nerve. So if sympathetic is blocked, there will be unopposed parasympathetic and it will cause bradycardia. Here the heart rate is normal, but it can cause bradycardia. Why patient having bradycardia? So we discussed this. What is epidural block, or what is epidural anesthesia? An epidural involves insertion of a large bore needle into the space between the dura and ligamentum flavum of the spine, extradural space, to provide a continuous infusion of analgesia for perioperative pain control. As the name shows, epidural, above dura. Management plan: call the operating consultant and anesthesian consultant, sit the patient upright, 100% oxygen, stop any injections in the epidural catheter, rule out any concomitant hypovolemic shock, epinephrine, phenylephrine, metforminol, inotropic agents, and atropine chronotropic agent increase the heart rate. So you have to inform the consultant which has operated on this patient and anesthesia consultant as well. First, rule out any hemorrhagic shock, because post-op there can be hemorrhage, and after excluding everything, then give patient O2, IV fluids, and inotropic support. Because such patients also has lost the vasomotor tone of the vessels, so you have to give inotropic support. What are the factors that affect the efficacy of epidural in its analgesia? So factors, patient factors: age, height, weight, posture. This can also affect the efficacy of epidural analgesia. And for example, a low weight person will need a little dose and will be very effective for him, but the same dose will not work for a 150 kg man. Epidural factors, level of medication that you are on, which level you are administering the medication, dosage, types of medication used, and vasoconstrictors. Why was epidural needed for this case? Longer surgery, better postoperative analgesia, and helps in early ambulation of patient, which will decrease the incidence of DVT and improves outcome. So, in spite of GA, general anesthesia, the hospital stays short, patient can move, so it will decrease the DVT or the also the pulmonary issues as well, and any other issue. Better postoperative analgesia for the patient. How to test the level of the block? Using temperature sensation with the help of ice packs. What else beside ice packs? Ethyl chloride spray. Ethyl chloride spray. Why we use temperature sensation? Because of the arrangement of fibers, the motor fibers are the last to be affected by voltage-gated sodium channel blockers, lidocaine, bupivacaine. Sequence of nerve fiber blockade by anesthetics, autonomic first, then sensory, then motor. Pain first, temperature after, and then touch, then deep pressure sense. Loss of taste, bitter first, sweet and sour later on, and then salty at the end. So do not give the patient pain, so you don't have to test the pain sensation because you are giving analgesia. So what's the purpose? Then what you can use instead of it? So you check the temperature. So if the temperature is lost, the pain is already lost sensations. So this is the trick that we have this order. So if temperature is gone, pain is already gone. Okay, so that's why you check the temperature first. Why temperature, not pinprick? So you never do pinprick because it can be painful, it can bleed, it can lead to later on possible infection if you prick the patient. Okay, how to differentiate high epidural block from hypovolemic shock? So in epidural, high epidural block, warm and pink peripheries due to vasodilations because of the loss of vasomotor tone and bradycardia. In hypovolemic shock, the patient will be tachycardic. This is the main difference. Here the patient will be bradycardic, here tachycardic. Cool, clammy, and peripheries in hypovolemic shock. What are the cardiorespiratory effects of epidural analgesia? Increased venous compliance, decrease systemic vascular resistance, venous return, cardiac output. So if you lose the vasomotor tone, so there will be huge compliance, increased compliance. So the blood will pool in the vessels. So systemic vascular resistance decreases and venous return increases in term. And then if venous return is, then there will be no preload or reduced preload, and it will lead to decreased cardiac output, decreased lung and chest wall compliance. Okay, and decrease FRC, decrease functional residual capacity. In what manner epidural can affect respiration? High epidural can block phrenic nerve C3, C4, C5 and intercostal nerve, causing respiratory paralysis. Okay, so what are the systemic side effects of epidural analgesia? So hypotension due to block of the sympathetic, as we already discussed, that there will be loss of vasomotor tone, loss peripheral vasodilation and pooling of blood. So decrease systemic vascular resistance, decrease venous return, decrease preload and decrease cardiac output, and so hypotension. Reduce cardiovascular due to reduction in the venous return. Attenuation of the surgical stress response. Stress response will increase. Uh, Reduction of FRC, functional residual capacity. Reduction of postoperative DVT. Yes. Mm, due to a number of causes, including the concomitant use of IV fluids used to support the arterial pressure. Yes. Who would you involve beside anesthetist, operating consultant? What signs and symptoms would you tell the patient is getting worse? Decreased baby, decreased heart rate, decreased saturation, paresthesia, and oliguria. So this was the epidural anesthesia block, and it was in the recent, I think, attempt as well.